Test 1 2 3. Test 3 2 1.
Committee for the Board of Managers at 1300 hours, Thursday, October 1st at 2020. Any citizens wishing to address the committee, Scott?
No, sir, Mr. Chairman. There are no citizens.
Then the matters requiring committee action. First is the approval of the minutes of September the 3rd, 2020. Entertain a motion to approve and a second.
This is Zim approved.
Webb, second.
Hey there. Any discussion? All in favor, please say aye.
Aye.
Those opposed say no. Okay, then the next one is approval of Tarrant County Hospital District policies and/or plans. There are 5, and we have to take them individually. So the first one is point of care, 100 point of care, laboratory testing. Karen Duncan.
Hi, good afternoon.
There she is. Hey.
Hey, how are you, Chuck?
Okay.
Before asking for approval of this policy, I would like to take this time to thank Dr. Stevenson, Wanda Peebles, and Ron Skillens for leading the much needed district's policy work. They now oversee a newly formed policy committee that ensures timely review of policies, ensures all policies are located in a central repository so staff can easily locate policies. This committee also works to minimize duplication of policies and, more importantly, ensures standardization of all policies and policy procedures. Ms. Walker has quickly been brought up to speed regarding policies and will be joining this team. Policies will now clearly state what the district will do, and policy procedures will outline the how. So for this policy, point of care, POC 100 point of care laboratory testing, it was noted that the policy also included the procedure. So you will see that the procedure portion has been redlined from the original version, and the policy coming before you today does not include the procedure. The procedure has been reviewed and moved to POC 104 entitled Point of Care Laboratory Policy Procedure. I am asking for your approval of POC 100 Point of Care Laboratory Testing that states that the district will remain compliant with the lab certifying and accrediting entities as it pertains to point of care testing.
That was a mouthful. Any comments for Karen?
Trying to explain all the redlining.
Explain it to the Reverend.
I got it.
Got it?
Okay, here's one more for you, Karen. Right in the middle of the policy, right after the Joint Commission is, it says a CMS agent. I know what that is, you know what that is, but the public wouldn't. So if you, for the first time, it appears on a policy, if you wouldn't mind just saying what that is. You got me?
No, I do not. What are you asking?
It's just under intent and scope, go to the second paragraph.
Yeah.
Second paragraph says the Joint Commission is a, then CMS agent. You and I know what CMS is. Anybody in the public might not.
CMS.
Center for Medical Services. Yeah, just
So you want to spell that out? I'm sorry.
Yes, spell it out the first time it appears in a policy, and then after that you can.
Okay, I surely will do that.
Yeah.
Thank you. Thank you,
Chuck.
Chuck.
Just my little bugaboo. All right, we've heard the presentation from Dr. Duncan. I'd entertain a motion to approve in a second.
Move approval.
That's
Zim,
Ralph. Zim is the second. Any further discussion? All in favor, please say aye.
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 Those opposed, same sign. Say no. Okay, resuscitation readiness. Wanda.
Hey, good afternoon.
Hey, good afternoon. Congratulations.
I'm here to present Patient Care Policy 600, which is our resuscitation readiness policy. This policy is make sure that we have resuscitation equipment, the personnel and the processes available in the event of an untoward event or cardiac arrest of our patients. This policy supports the procedures for our Code Blue procedure, our MET team procedures, and our Psych resuscitation procedures. The only real change on the actual policy was changing the word clinical staff to medical staff, and then the abbreviation of JPS to JPS Health Network.
All right, any questions for Wanda? Anybody? Hearing none, entertain a motion and a second for approval.
Zim move to approve.
Is that Zim?
Yep.
Need a second.
Webb, second.
Okay. Discussion. None? All in favor, please say aye.
Aye.
Those opposed say no. Third one, PSY 1000 legal rights for psychiatric patients. Zelia.
Good afternoon, everybody.
Hi, Zelia.
I'm here today to present the Psych Policy 1000 legal rights of psychiatric patients. Basically, what we did is we updated the mental health code to the 21st edition with the Texas Administrative Code, which governs psychiatric patients' Bill of Rights and legal rights. And we updated the policy number to the new requested policy system that has been implemented that Dr. Duncan referenced a few moments ago.
All righty. Any questions for Zelia? Seeing none, entertain a motion for approval and a second.
Move approval.
Anybody else want to jump in?
Second, Webb.
Okay. Any discussion? Hearing none, all in favor, please say aye.
Aye.
Those opposed say no. Okay, Zelia, 1100 transportation services for psychiatric patients policy.
Yes, and this policy, again, the policy number was updated. We did make some small grammatical corrections, and we added the Texas Health and Safety Code because if you're an involuntary patient, there are certain requirements according to the Texas Administrative Code regarding transportation that's a requirement for us and our patients. And so that's what this policy does.
Great. Questions for Zelia? Seeing none. Seeing none. Entertain a motion for approval and a second.
Move approval.
By Ralph Waldo Emerson and
Zim seconds.
Jim second. Discussion. Seeing none. All in favor, please say aye.
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 Those opposed, no. Okay, the last one I have, Karen, is MM300 anticoagulant management program.
Thank you.
Yes, I'm asking for approval of policy MM300 anticoagulant program policy that states that the district will establish an anticoagulant therapy program that manages the risk and harm to patients associated with anticoagulant therapy. Minor wordsmithing change was made to the previous approved policy.
Okay. Comments for Karen? Seeing none, entertain a motion and for approval and a second.
Move approval.
Zim second.
Jim second. Discussion for anybody? All in favor, please say aye.
Aye.
Those opposed say no. All right. Those are the action items. And the next, at least for me, the cool part, consider performance improvement reports updates not requiring committee action. The first is a PSI 90 update. Rob Stevenson. Are you on there, Rob?
I'm here. I didn't unmute. Yeah, can I have the first slide, please? Share the presentation. There we go.
You got it. I can't see.
There we go. Now we go. All right, next slide, please. Great, next slide, please. Is there any way you can increase its size on the screen? It's very small, hard for me to read the numbers. I don't know how all you all are seeing it, but anyway. So
Rob, before you go on, what came out in my folder is a little blurred.
I agree with that as well. That's another reason why I wanted the screen made a little larger so that folks can see, and you know, those people watching on YouTube would, I think, have a lot of trouble seeing these numbers as well.
Okay.
So if there's any way we can get the numbers made larger, that would be great.
Rob, while we're waiting.
I'll just try to speak to it. All right. So so this is now 11 of 12 months for the fiscal year 2020 in terms of our results with PSI 90, and to remind the members of the committee as well as those who are watching on YouTube, PSI 90 is a risk-adjusted weighted measure of 10 different serious safety events that happen in the hospital, many of which are particularly tagged to the post-operative period. The measure is ultimately reported somewhat as an observed over expected. So if your number is 1, then you're performing at expected based on the kinds of patients you're taking care of. If your number is above 1, you're performing worse than expected. And if your number is under 1, you're performing better than expected. So after now 11 months, I'm trying to see the number, but I think the number is currently at 0.91, which is which is well in threshold, well in the target range, not quite to stretch. If you go back and look at June and July, you can see those 2 months were a little rougher for us. Those were months where we were getting particularly impacted by a lot of very sick patients with COVID-19, and the measure that was impacted by that, as you can see, and as we discussed in the last couple of quality committee meetings, were in terms of pressure ulcers. These patients who are very sick, often requiring chemical paralysis during their ventilator course in order to get enough oxygen into their lungs, and also required weird repositioning. Like, for example, a lot of them were had to be maintained on their tummies on the ventilator for long periods of time. So with a situation as well where if they were turned or manipulated or moved, they would oftentimes lose their oxygen saturation. So with that big load of patients, we did get hit with some pressure ulcers, and and that was certainly very tough for our patients and tough for us. But in any case, in August, the pressure of COVID began to reduce, and you'll see that in a graphic in just a little bit. With that, the pressure ulcers, thank you so much, that's great. So the number is 0.93, it was so small I couldn't quite read it. Areas of strength for the year have been probably most notably in terms of postoperative DVT, deep vein thrombosis, and pulmonary embolism. So these are the blood clots that people get in their legs from prolonged immobility, especially in association with whole body inflammation that you get with surgery and other serious illnesses. We had a rate that was much higher than we would like prior to this fiscal year, and with tremendous attention put on the issue, a lot more awareness among our team members, as well as a lot of work to develop risk assessment tools and order panels so that our patients receive the correct anticoagulants and other interventions to prevent these events from occurring. We've been able to drive that number down from 3.27 in fiscal year 2019, and our rate now is 1.56. So that is a tremendous improvement year to year. The other areas of improvement, we've had some improvement in postoperative sepsis, and we've continued to perform well and even improve in postoperative respiratory failure. So those have been areas of real strength for us during this fiscal year, and it's resulted in another year of very strong performance in PSI 90, even given that we had to contend with some additional challenges associated with COVID-19. Next slide, please.
Dr. Stevens.
Yes, sir.
I think I asked this last quality meeting, so forgive me if I'm redundant.
It's okay.
I thought I asked if there was a possibility or how we could separate COVID-19 patients versus that regular patient who comes in for illness. Because when you said some of the numbers were up because of the COVID situation, can that be broken out so we can see the disparity between the two?
Yeah, we could probably run a PSI 90 on the COVID onlys. The one thing that would be a little weird in that population is most of those folks don't get surgery, and as you can see, 3, 4, 5 of the, it's actually 6 of the 10, 7 of the 10 measures are directly related to having surgery, and so most of the time, COVID-19 patients don't get surgery. So for the overall measure, it would be not probably a great measure for COVID patients, but we could certainly, it would be an easy matter to take the COVID patients out of the mixture and show that measure, in which case I think our performance would be pretty strong, because if you, 5 of the 6 pressure ulcers, for example, which is what drove our numbers in June and July, were in COVID patients. So if you look at where we were performing before all that happened, we had a PSI 90 rate under 0.9, significantly under 0.9. So we'd probably be looking at stretch performance for the year, I think, pretty legitimately without the COVID patients in there, just as a gestalt. And interestingly, it's a great point you bring up, Reverend, actually, because there is some vague guidance, but there is guidance from CMS that they may be excluding these patients from their analysis of this year when they finally do it. It's delayed almost 2 years from the time of the occurrence. So using the government's measure is a little bit delayed and is hard to react to. The measure that we use here, that we're looking at here, is based on using a computer program called MIDAS to abstract cases from the coding and documentation that we have on our patients, and then we use that program to make an estimate of what the government would ultimately measure for us, 18 to 24 months down the road. But it is quite possible that when they finally assess this year, that those patients will be excluded from their analysis, which would be obviously, I'm sure there's a lot of pressure on them to do that, because everybody has been struggling with the challenges of taking care of this uniquely sick population that is all very new to us. So I'm sure I think there's probably a very good chance that they're going to be excluding those patients, but right now the guidance is too vague for me to say that with certainty.
Okay.
Okay, next slide, please. So continuing on the rest of the quality scorecard, one great success for the year so far is really our colon SSI. I think I mentioned this last time, but we had a real spike in colon SSI when some of our processes were disrupted at the beginning of the pandemic, and in the matter of about a month and change, we had 7 colon surgical site infections. The great news is that we were able to make a lot of process change around what we're doing for these patients, get our processes back where they needed to be and where they were before, and we so far have now gone 3 months without an additional colon surgical site infection after we had that spike in late March, April, and early May. And year to year, in terms of the total number of infections, we're still ahead of last year's performance at 9. So 9 versus 12, and we really only have, I've seen the August data, so we really only have 1 month left to go in the fiscal year. So I'm hopeful that we're going to end up ahead of last year's performance there. And again, it's because a whole lot of people, we were able to identify this as an issue quickly and get people together to address the spike and get our processes back where they needed to be. The other area of struggle has been in terms of central line associated bloodstream infections. Most of this, of the big spike that we had in this group, and you can see we had 9 cases in July, were related to COVID, and so so that was a particular challenge for the year. Without those patients, we would actually be slightly ahead of where we are this year, and even in the previous months in April and May, we had most of these infections in the COVID population. So I have not seen any guidance from NHSN, which is the group that tracks these infections nationally, that they're planning to exclude the COVID patients. But I can promise you that this is a struggle that everyone's been having. So there probably will be some national pressure on them to make some adjustments here as well. The catheter-associated urinary tract infections, again, as well, had some challenge associated with COVID, but we've had such great processes around prevention of this adverse outcome that we're dramatically ahead of last year's rates. So last year we had 28 of these. Currently, with only 1 month left to go, we have 13. So this is really a tremendously improved performance year to year. Next slide, please. So this is just the PSI 90 month to month. You can see that the tough months were April, when we had our hospital full of patients with COVID from the federal prison, and then June and July, when we had the real spike from the community. Next slide, please. And this is just a clearer look at the different type of measures, so you can see that great improvement in perioperative deep vein thrombosis and pulmonary embolism. But we have seen some nice improvement in postoperative sepsis, as you can see, and continued good performance in postoperative respiratory failure. You can see we've only had one event of that sort for the whole year. So if we get through September without one, that will be a nice improvement year to year. Next slide. Oh. Reverend, did you have a question for me?
I can see him, but I can't hear him.
I think he's on mute.
He is.
No, I didn't have a question.
There we go.
Thank you, sir. I just thought I heard you saying something, so I wanted to make sure we...
No, I started to say something about changing my mind.
Okay, sounds good. Perfect. We'll now turn it over to our patient experience presentation with Laura Burnside.
Thank you, Rob. So I wanted to start today, good afternoon, everyone. Hello, can you hear me okay?
Yes.
All right. Hello, everybody.
Hey.
Wanted to start this presentation with the follow-up information that you requested last month. If we could go to the next slide, please. These are the results for the very first mastery program that we conducted here at JPS. So this is a group of physicians, and these are the outcomes that we receive based on their participation in the mastery program. So the sections that you see here are the different questions that are asked on the survey on the outpatient side. And I do just want to remind the board that this survey is not a satisfaction survey. It does not ask patients how much they like their care or how much they like us, but rather what it does is it has a direct tie to quality outcomes. So what you see on the bottom of each of these sections is the questions that are listed. So how often did the provider explain things in a way the patient could understand? How often did the provider listen? How often did the provider show courtesy and respect? How often did the provider spend enough time with the patient? And then the overall rating of the provider. The numbers that you see reflected on the bars are top box scores. And what top box means is that it's the highest answer choice that the patient can make. So for instance, just generally speaking, if the rating scale is always, usually, sometimes, or never, the percentage that you see on the bar is the percentage of patients that were surveyed that chose the top answer choice of that rating scale. So in that example, they would have chosen always. On the overall rating of provider, the top box answers are a 9 and a 10 on a 0 to 10 rating scale. So the percentage that you see there is the percentage of patients that rated on that top box answer once again. The first bar in each of these sections shows the results of the cohort participants prior to the mastery course. The middle bar shows what their results looked like during the course, and the green bar shows what their results look like today. So it's after the course is over. What's interesting to note is that as I mentioned, these results are for the participants in the cohort themselves. We did not see this same type of adjustment for the physicians that were not included in the cohort. Next slide, please. Are there questions on that? Okay. This is our second cohort and the results that we experienced from the second group that came through. This was an interesting study because it was actually 15 OBGYN residents. So Dr. Huang, who was a graduate of our first cohort, decided that she wanted to facilitate and conduct a mastery course for her residents. And so the results that you're seeing here are for those 15 residents that are part of OBGYN. And again, the first bar shows the top box results for pre-class, and then the second bar, the green bar, shows the results post. This class was interesting because we actually could tie their results to the inpatient side as well. So if you'll go to the next slide, please. What you'll see on this slide is actually the unit results overall based on the units where the residents actually practice. So 2 North and 2 South are women's units. And so what you'll see here, these are actually percentile rankings. So prior to the mastery course and the residents participating in that, 2 North was at the 92nd percentile, so incredibly high performance. After the cohorts went through the class, they actually raised the percentile ranking for that unit to the 96th. And that is top 5% of the country, top 4% of the country. The second set of graphs that you see, or bar graphs that you see, is for 2 South. That's also a women's unit. They were in the top decile as well at the 90th percentile. But after the mastery course graduates completed their course, the percentile ranking for that unit actually went to the 92nd. Again, very, very, very high performance levels. And that's compared against every adult acute hospital in the country. So it's a very, very large database.
Great.
If you'll go to the next slide, please. You asked for what did the physicians and the APPs say and the other participants in the course say about it. We actually included all of a whole page full of comments. We sorted out a few of these for you just to kind of give you an overall feel. But we hear this through every cohort that comes through, and there are things like, I felt like I had several small aha moments throughout the program, picked multiple tips and tricks to use, and really has impacted their overall practice. Interestingly, we had reached out to one of our postgraduates a couple of days ago, and yesterday I got a response back from this physician, and he said we'd asked him to actually facilitate a course this coming week, and he said he would absolutely love to participate in the course. He felt like the course has absolutely improved his connection with patients and subsequently their outcomes. He's extremely grateful for the opportunity to participate and wanted to support the mastery program in any way. And then he went on to say that his wife is also a physician here, and he wanted to recommend her for an upcoming cohort. There's also a video that our communications team did putting together just feedback from some of our participants. That link is available for you, and we included the YouTube address as well. You have seen that. We've shown that actually a few times during board meetings, but if you wanted to see it again, it's very short, 2 or 3 minute video that you can watch on YouTube, and it really does give a very strong feel for the way our participants view the course, whether they're on the physician APP side or the operational leader side. Did that answer all of the questions regarding feedback and results from the mastery course?
It did for me. And anybody else got questions for Laura? Okay.
Okay. The next bit of follow-up was actually related to telehealth. And the question came up about how do we measure our telehealth visits? And so what you'll see on this slide is the different questions, again, that relate to the physicians. The blue bar, the very first bar, again, these numbers that you see on the bars are the percentage of patients who answered top box answers. So that very highest answer that they could choose on the rating scale. And then the sections are based on questions. This data is actually April 1st through today. So it's real-time data for phone visits, clinic visits, and telehealth visits. So you can see the difference in the way that our patients perceive the different types of visits. So the first bar, the lighter blue bar, if you're looking at that, actually shows our phone visits. The green bar in the middle shows our telehealth video visits, which we were able to implement once we got telehealth up and running. And then the last bar shows our clinic visits. And as you can see, our patients actually prefer the video visits for the most part over the other types of visits that we have. That being said, we had never done any training on how do you conduct a really strong telehealth visit. So we took our mastery program format and we developed a minor in telehealth. And it was a 3-part series on basically how do you set up a really strong video visit? Where do you look when you're talking to a patient, even things as simple as that? How do you use technology to be able to show tests, results, radiology tests, that kind of thing to a patient when you're in telehealth mode? And then how do you do a really strong close with the patient to ensure that they understand their treatment plan and can comply with it? And what we found were some really significant outcomes from that as well. And interestingly, some of the feedback from the physicians were, they didn't go to school to sit in front of a computer, right? I mean, that wasn't exactly what was in their plan. And now all of a sudden that's the mechanism that we had. So there was a little bit of adjustment that came into play. And it was really fascinating to me to hear the story of a physician who actually conducted a telehealth visit with a patient who was at work. And he said, if you'd ever told me I was going to have a clinic visit with a patient while they were at work, I would have thought you were crazy. And I was a little irritated by it at first because I thought, this isn't the way it's supposed to be. And as they continued through their visit, the realization for the physician was this patient didn't have to leave work. They didn't have to drive over to a hospital or the clinic. They didn't have to go through registration the way they normally do. They didn't have to sit and wait while we were getting ready for their visit. They actually just received a phone call at their clinic visit time, and they were able to conduct the entire visit in a very short period. And what's important about that today is at this particular period of time, there were so many people who were out of work. So being at work and having a job was incredibly important for our community. And this allowed our patients to be able to continue to earn a living and still be able to receive the care that they needed. And so I think, through that, we realized that this is really a win-win for our patients, and we have the opportunity to really impact the way that we take care of our community using electronic versions and technology of regular clinic visits. Next slide, please.
Pretty impressive.
Yeah, it's been a lot of fun, actually. We've had some tremendous partnerships with our physicians and APPs.
Laura?
Yeah.
This is Reverend Emerson. Before you move go to this slide, you don't have to flip back, but the last two slides, one were very impressive on the improvement, where we were to where we improved to. So my question is, then, was it a kind of a sort of an encouraging wake-up call for the physicians to say, hey, maybe, I mean, I'm encouraged to look at how I'm doing my practice and providing the service that it motivated them to step up a little bit? Is that
Yeah, I think so. I think seeing the results and the way that patients are responding to it is always a benefit. When patients are responding positively, it makes you want to do it more. When we had about 50 people or so in the telehealth series that we did, and the feedback we received from that series was, the little things matter when it comes to video, and how we pay attention to the video, for instance, and how we look into it and really make sure that we're being attentive. And our patients responded to that really well, but our physicians were really appreciative of the tips and tricks. And they're not hard, but if you're not used to it, and it's not intuitive. So laying out some of those very simple tips and tricks for how to do it effectively help them feel more comfortable. And our patients are responding to that in a very positive way.
Well, also, I'm speaking not just the telehealth, but the slide prior to the telehealth.
Oh.
The very first slide, No, the slide before that.
Before that, the one for the inpatient results from one of the cohorts.
Yes.
Yeah.
Yes,
if you'll go back one more slide, please.
Oh yeah. Yes.
That
Okay.
slide.
They were at 92. They went to 96. They were at 90. They went to 92. So by going through the program, that's what I was asking. Are we discovering now that maybe it's an enhancement or encouragement to the physicians that
yes,
they're looking at how they are practicing?
Yes. Thank you for clarifying your question. Yes, what's been really fascinating with the Mastery program is we introduced the survey and the scoring system, if you will, in our nuts and bolts session, which is our first class. But we don't talk about score again until the very end, and we show them their results. And the reason we do that is we know that the score is a reflection of the work that we're doing. When we do the right things for patients, our results move. We know that. What's neat for the physicians and the APPs who have gone through this is because we haven't said, you've got to get your score up, you've got to get your score up. Instead, we focused on, let's think about ways that we can explain things to a patient so they can actually understand what you're saying to them and comply with your treatment plan, ultimately getting better faster. They see it as a benefit to the quality of care that they're providing to their patients rather than it being a score. And we've seen a significant difference when we've pulled people through that thought process and that analysis of why are we even measuring this? It's because we want to be sure that we're taking great quality care of our patient that's very human-centered. And when we do that, the results move.
Okay.
So yeah, it feels good. It's actually helping with engagement levels. It's helping reduce burnout levels. They're feeling much more energized and invigorated from the visits they're having because they're much more meaningful than they have been in the past.
So do you see this as something that will be ongoing with the physicians?
Yes, so we have actually enhanced this. So we have a regular patient experience 101, which is what you're seeing here as far as results. The telehealth series that I mentioned to you, we have one already developed for emergency services that we have given twice already. We have a third cohort going through shortly. And we have another one that we developed for our community healthcare practice managers. And it was all around caring for you and then caring for your team, which ultimately takes care of our patient. So we framed that one a little bit differently. And then we have another mastery program that's coming. It should be released in the next 30 days or so. That is the fundamentals of integrated ethics. And so what we've done is we've taken this platform of a structure that we've created, and we are actually developing it, increasing it, and creating additional programs that we're pulling people through. And all of them have had really remarkable results just like this.
Okay. All right.
Yeah.
All right.
You're
Thank you.
welcome.
Pastor Emerson, what
Laura is not telling you is the fact that this program has been so successful and it's engaged our physicians and our nurse practitioners so well that we are receiving requests pretty much on a monthly basis from other hospitals that have heard about this program, and they actually want JPS to come to their facility and teach them how to do this. So in our budget, you approved a small amount of money that would go to Laura's office to begin to incorporate this for other hospitals, and we think this actually could bring income into JPS. So we're really excited by it, and it has had huge impact. Now, I will tell you that many people's eyes will glaze over, and even people within our own administration will say, do we really need that? Do we really need that? That seems like a soft gray area. Brian Webb can testify to the fact of what it's like to work with colleagues that are engaged. Brian's always been engaged. Brian always wanted to serve on committees. He always wanted to play a role. But when I first joined JPS, we could, and no disrespect, but we probably had about 14 physicians that wanted to play that role. Now, from our TCU cohort and the program that we've done here, we probably have over 90 to 100 doctors that are vying to get in these programs. So thanks to you as a board that allowed us to do this, but this is not a squishy gray area that doesn't mean anything. It's made huge impact, and Brian's a prime example, and I would compliment Brian Webb if he were at this meeting or not at this meeting.
Thank you, Robert.
Yeah,
you betcha.
I would as well. Yeah. Does that answer your question, Reverend?
Yes, I'm
Very
good.
Yeah, Laura,
yes.
What I encourage anybody to do is we should always be looking at healthcare through the eyes of the patient.
Yeah.
And that's what these programs do. It enhances what the patients feel and see, which is an integral part of their quality experience.
Yes, you're exactly right. And the premise behind this program, if you're a physician or an advanced practice provider, we ask you to look at this through the eyes of the patient. And if you're an operational leader here, we ask you to look at this through the eyes of the physician or the advanced practice provider so that we can create partnerships that are stronger and more understanding of each other. And then we take care of the patient better. So you're right. It's all encompassing.
So I would say good job. Keep it up.
Thank you. The last moment of follow-up, if you will, was regarding our Pbx operators. So when you call the main hospital number, you are going to hear a greeting that sounds like this. Thank you for calling the JPS Health Network. My name is Laura. How may I help you? And our operators use that script and answer calls almost 59,000 times a month. We have 11 operators right now that work in this space. Their average talk time has not really adjusted since last year, but what has adjusted are the number of calls that are coming through now. So they're taking about 11,000 additional calls per month today over this month last year. So same time last year. These almost 700,000 touch points to our patients are really critical because it's almost always the front door to the hospital. What we've also seen happen with the increase in number of calls that are coming through is our talk time, or wait time rather, has increased, and it's almost doubled. It's not outlandish. It's at 44 seconds right now, but we are working with our human resources department to really review the productivity standards and measures to make sure that we're staffed accordingly so that we can manage the volume of work and get that back down into the 20-second range. The top 3 reasons for calls at this time, this does adjust and change based on month and what's happening in the community, are listed over there for you on the right. And then what this allows us to do is take the trends that are coming in and proactively work with our partners in community health or in communications to make sure that we're developing messages and processes that are easy for our patients so they can navigate our system appropriately. What questions may I answer regarding any of the follow-up items that have been covered?
Laura, who answers the three questions? Like, are we allowing visitors?
Our operators.
Yeah, they're great.
Yeah, we've really empowered them to do quite a bit. So they can answer any basic questions. They can confirm appointments and appointment times, locations, give addresses, give directions, all those kind of things. And that was not the case a few years ago. They would just transfer the call and move on. But through our partnership with Community Health, we have opened up some of the, we've actually worked with them with the most common questions and gotten the answers so that the operators can handle those with first call resolution for our hospital, for our community members calling in.
Great.
Okay. Next slide, please. We can move on to our organizational goal update. This is our inpatient, you can go to the next slide, please. This is our inpatient measure right now, which was to improve our dimensions to the 75th percentile. The reason that we did this was because we wanted to make sure that we were focused on all aspects of care that are important to patients. We are now achieving 5 of our dimensions in the top 75th percentile, or top 25% of the country, which is considered top of the country. I did include our action items on here for care transitions because that is our standout dimension, as we talked about last month. We're at the 15th percentile right now, which means 85% of hospitals across the country are outperforming us. So we are putting in place some very specific action items to move the results of that dimension and better care for our patients. And the questions that are in that dimension itself are related to, did we take patient preferences into account in deciding what their healthcare needs were after they discharged from the hospital? Did they have a clear understanding of their responsibilities in managing their health? And did they fully understand the reason for the medications that were prescribed? And so as you can see, again, those are very clinical questions, very quality related questions. And we are beginning our multidisciplinary care transitions committee. In fact, it kicks off the entire committee today. So we are moving very expediently to be able to move that dimension along.
Laura, will care transitions take into account the waiting times in the emergency room and throughput and all that kind of stuff?
Well, indirectly, yes, right? Because so many of our patients come through the emergency department. And so the experience that they have from the moment they step through our door impacts the end result as well. And so we do have specific work that we do with throughput with the emergency room physicians. It's why we developed the Emergency Services Mastery Program, to try to bring attention to ways that we can make that very first impression really count as the beginning of a really great care stay while they're here.
Laura, would you mind if I made a comment?
No, please.
Thanks. So care transitions, in terms of as a experience dimension, is really probably the one that is most linked to quality outcomes. And so it's something that I've been very, very interested in. I'm very excited that this work group is kicking off today, and some of our performance excellence people from my group are helping to sort of, do the process part of that, and Laura's new executive director in patient experience is really one of the national leaders in understanding how to drive care transitions. But it also does, sort of to your question, have very direct impact on overall hospital throughput. And the place where it has the biggest impact is on return to ED and readmission rates. Because when patients don't really understand how to promote their health when they go home, and they don't know or don't have their medications and are confused about that, they're a whole lot more likely to have to come back in the hospital, because something's not going to go right when they go home. So this is really a vital effort as an organization to get this right. And so I'm unbelievably happy that we're going to be putting huge focus on this. And I'm really grateful to Laura for her partnership on this, because it's something that, I think anybody who's really interested in quality outcomes is going to be very interested in seeing improved. So So anyway, I'm really excited about the effort is all I really wanted to say.
Thank you, Dr. Stevenson.
Laura,
Yes.
can you explain what is responsiveness hospital staff? What is that?
That's actually a dimension, and the question that is related to that is, there are two. After you press the call button, how often did you get help as soon as you wanted it? And then the second question is, how often did you get help in getting to the bathroom or in using a bedpan as soon as you wanted it? So as you think about how does that relate to quality? Yes, we want people to respond to our needs as fast as we can, but the real reason that we ask the questions in that dimension are so we prevent falls.
So we prevent falls, you said?
Correct.
Okay. All right.
Yep.
So is that 61st? Where is that on the level? Is that below scale? Is that with meeting scale?
Well, we're striving for all of these dimensions to be in the 75th percentile. So the 61st percentile is above average nationally. And again, remember, we're compared to every hospital in America.
True, right.
So we're above average in that dimension, but we're not quite at goal. And so that's another one that we continue to work on. And we do that through a tactic that we use here at the hospital, primarily called hourly rounding. And they're really hourly safety rounds. So making sure that all of our care team is doing those on an hourly basis will help us with that responsiveness issue. And that is also part of our action plan as we move forward.
Who is a part of that team that does the rounding? Is that?
It's nurses and techs primarily. However, anyone in the hospital could conduct an hourly safety round. And that's really the ideal state, is everyone who's in the room of the patient is conducting those safety rounds.
Okay.
Yeah.
It was just seeing to me that particular category is somewhat subjective. My thinking, if you got there in 5 minutes, might have been too slow based on, you know, or the mood of that patient at that moment, you know.
Yeah, if you think about it, by the time a patient actually calls for help, they probably already needed it. And so, it is one of those things that we try very clearly to be very proactive with some very specific things. So during the hourly safety rounds, for instance, we're checking a variety of things. One is, does the patient need to use the restroom? Do they need to be repositioned? And again, that is to prevent those pressure ulcers or bed sores. Do they need to have their pain, you know, are they having issues with their pain? And do they have everything that they need in a space where they can actually reach it? And what we find and what research shows is that when we cover those four things proactively, this number, as far as patients' perception of responsiveness, increases and falls decrease. And so that is a measure that we look at and work very, very closely with our care team on all the time.
So are we asking that patient, without them aware of it, the questions that are on the survey? Example, are your needs being responded to in a timely manner, or something of that sort?
We do during like leader rounds, we reference the topic. We are restricted through CMS from asking the question specifically or even referring to the rating scale.
True.
But we do know that these are the topics that are important to patients, and they're the actions that we're taking in order to take great care of patients. So during our leader rounds, yes, we reference questions all around this, you know, but we ask them in a different way so that we remain in compliance with CMS guidelines and avoid any of the pitfalls that we might fall in as far as the restrictions.
All right.
Yeah. And, you know, as far as care transitions, I would share with you, this is a minimum of a year-long project, so I wouldn't anticipate that we will hit the 75th percentile tomorrow. So please be patient with us as we work through that, but understanding that we are very, very dedicated to making that difference.
Okay.
Other questions, Reverend?
No, that's it.
Okay, and then this is our final organizational goal and final slide. This is for our outpatient world, and we are right now hitting between threshold and target, and these are, again, those top box answers. We did not have a percentile ranking benchmark to use because this is a new survey that we get back in real time. And so what you're seeing, that's why the difference in reporting. So this particular goal, I'm really pleased with the community health team, and they had their highest results in August ever. And what you're seeing on here is not the telehealth data, it's strictly inpatient, in-person clinic visits, because that's how we wrote the goal. So we will continue to show you telehealth data, but just understand that what you're seeing here this year as part of our organizational goal is just inpatient visits. So shout out to community health because August hit their highest results ever, but we are hitting at least thresholds in our organizational goal. And then you can see the action items that are there on the side. Are there any questions that I can answer?
Provider new medical history seems down across the board.
Yes, and that is, it's interesting because when we look at our telehealth data on that question, it's actually very high. And so we're doing a really good job of it when we're talking with the patients over phone or video, but we're not doing as well when we see them in person. So we will tackle that because that's an easy one to move, actually.
Okay.
Hey, Laura, can I make a doctor comment for Dr. Weber?
You absolutely may.
So Dr. Weber, this one's a weird one because it requires unlearning something that we learned in medical school.
Uh-oh.
Which is that when we walk into the room, the first thing you were taught is to say, "So why are you here today?" And that, as it turns out, says to our patients, they have no idea why I'm here today. They have never looked at anything to do with my records. Right. This guy's clueless. So, but we're told to start with an open-ended question. And yes, that is important. But what you want to say before that is, I have reviewed your records and all of your test results. But I'd like to know, in your words, why you have come in to see me today.
Right.
So that I can make sure that we focus on the things that are most important to you. And just that little turn of phrase says a completely different thing to our patients about what we have done to prepare for their visit. Because of course we've of course looked at their records before that we go into the room. I mean, you never want to go in blind if you have information. So we do that. We actually do the work. It's just about giving our patients the confidence that we have in fact done the work. So the challenge is that we have to, whenever you have to unlearn something, there is a barrier to get over. And so that's one of the things that the mastery program is tackling, and one of the reasons why we're seeing such great movement in the scores for our physicians, because we're helping them to unlearn those ingrained lessons of the past.
Oh, yeah. Great. Good.
Thank you for sharing that, Dr. Stevenson. That's so much of what we do, and it's hard. It's easy to understand it, but it's very hard to put it into practice, which is why these results are so difficult to move. Our database is enormous.
And I will tell you, Dr. Weber, and from all your years here at JPS, just that little explanation that Dr. Stevenson gave is so powerful. That moved the meter on patient satisfaction so significantly. Every time Rob Stevenson walks into a room and says it like that, people feel totally different. And when you, Dr. Weber, have preached since the day I came here about patient focus, there is no more patient focus than that. And I applaud Rob because he has come such a significant way of making things better for our patients, but also many of his colleagues. It's wide, and I am bragging on JPS because I'm so proud of them. I'm so proud of the doctors. So when everybody gets all caught up in all the crap going on, and well, we did this to a claim, and why this and why that, we get caught in minutia. We're missing the big point, and the big point is how many unbelievable things our doctors are doing at JPS to turn things around for our patients. They've always been good at care, but now they're getting a response from patients. And Dr. Weber, you know this, we were told at one time that, quote, the patients we get are never going to be responsive to that.
I remember that.
Yeah, if I was a cussing man, I would employ one of those words right now, but I'm not. And I would tell you that that's what's made a huge difference in JPS and its patient SAT scores. And I couldn't be more proud of our doctors. Sorry for the editorial, but it's important to me. And guys like Rob Stevenson and Brian Webb and some of the others, that's the ones who've turned it around for us.
Excellent.
What are we doing to Psych? As long as I've been on the board, it's always been a problem. The ease to get appointment and provide in a timely manner.
So the access to the provider questions are ones that we are working directly with our community health partners on. So we now have a weekly call with our Access Resource Center team, and we are working directly with them to make sure that we are set up so that our patients can actually schedule appointments through the call center is one way. The other thing that we're doing is we've implemented one-click scheduling, and my chart has the availability for patients to schedule appointments through there. So we are, again, working very closely with our community health partners to help move the bar on those areas, because access to care is going to be very, very important. Again, going back to a lot of the lessons that we've learned through telehealth, we need to really look at how can we apply those to the inpatient visits as well. Because part of, again, if we go back to the story about the physician doing the clinic visit while the patient was at work, that patient didn't have to wait at all. And so, you know, that is an area that we are continuing to work on, again, through our partnership with our community health leaders.
Okay.
That's all I have. Thank you so much for allowing me to follow up and share, and thank you for your questions as well. Just some additional information there for you that was in your package.
The eligibility for the Hcap survey?
Yes, that came up as a question during the last board meeting as well. And so that shows you who's eligible for an Hcap survey and who is not. And then the other attachment that was there are just the additional comments that we have collected through some of our cohorts that have gone through the mastery program.
Laura, how come the patients discharged to nursing homes and skilled nursing facilities are not eligible?
So as far as, so the ones that are, so the nursing home, I don't want to say this wrong. So the patients who are discharged to health facilities outside of a nursing home are discharged to other facilities where their care is then continued. And so the Hcap's guidelines are just, and the CMS guidelines rather, are just that those patients would not receive a survey from us here. There's a continuation of their care that's happening.
I don't know why, but okay, CMS regulation.
We follow guidelines. Thank you so much, Dr. Weber.
Okay. And the last page is the comments and feedback from people that have.
That's correct.
No, I think it's good.
Supplemental information for you. And there's the link for the video in case you wanted to pull that up on YouTube later tonight for fun watching.
Okay. No, that's great. Keep it up. The next one I have is COVID-19 update. Michael or Rob going to do it?
I'll speak to it. This is a much trimmed down version compared to the other ones that we've had. But I think that this slide here brings out a very important point about the pandemic, which is that it's so dynamic that this slide and the story that it tells is already terribly out of date. And we put this together, Dr. Weber, in advance of our prep meeting last week. So 1 week, already completely out of date. So the story I was going to tell you last week was that we had sort of been fairly stable in terms of our COVID volume, stable to decreasing through late August and September after we had experienced that very large surge in late June and July. We are on the way back up, actually, in terms of our COVID volume. As of 11 o'clock this morning, we are now at 66 COVID patients in the hospital. So you can see that's getting into the range that we saw with the May spike that was associated with our patients from the Federal Prison Medical Center, FMC Fort Worth. So we are, there is actually some modeling which from some quarters that suggests that we could surge again as we get into November. But again, we're keeping our eyes on this. Right now, our hospital resources are not overwhelmed, certainly in terms of COVID patients, but we have gotten a little bit busier again as compared to where we were through late August and through most of the month of September. This is perhaps not a surprising recurrent pattern. The surging upward of cases, the gradual increase of cases that we saw in June really started about 3 weeks after Memorial Day. This uptick is about 3 weeks after Labor Day. So there's something about long weekends in Texas that seems to have something to do with us all getting together and letting our guard down a little bit, and then we see those cases coming back. Once again, we are seeing somewhat younger patients in the hospital with COVID again, and we haven't had very many deaths from COVID in recent weeks, but we remain concerned that with the younger patients getting it again, that eventually those younger patients will interact with parents, grandparents, aunts, uncles, and other older individuals that they come into contact with, and that we could see difficulties again in the hospital setting with older patients coming in again. What is clear is that COVID's not going anywhere. It's here for the foreseeable future. It doesn't seem to be changing in virulence. It doesn't seem to be changing in virulence. The patients who get sick with COVID still get very sick, still require ICU care, still require prolonged ventilator courses frequently, or at least very high flow oxygen for prolonged periods of time. So it remains something that is going to be either in the background or the foreground as it ebbs and flows until at some point we get effective therapeutics or a vaccine.
Rob, of the 66, how many are in the COVID ICU?
Right now, only 10.
10.
Dr. Stevens, what you just showed us, the graph and the data you're giving us, is that what is reflective county-wide also?
Yes, yeah, the incidence of new diagnoses for the last 3 weeks is significantly above the baseline that it had been for the previous 5.
Okay.
So yeah, no, this appears to be a county-wide phenomenon. I wish I could say that we're surprised. We always, whenever we see stability or declining numbers, we want to be optimistic, we want to be hopeful, and then the biology of the virus proves that it's a pretty persistent problem. And we've seen this around the world. I mean, openings up in countries that have had the disease under good control have those places have experienced new cases. So it is a very persistent problem globally. And you know, it's, again, I think that, I mean, most people think it will be with us until we either have effective therapeutics or an effective vaccine.
Okay, anybody else have comments for Rob? Rob, thank you.
Of course, thank you.
Now for the innovation corner, the stroke program.
All right, so Lori and Dr. Huggins, if you're both here, if I may I just say a couple of introductory remarks?
Please.
You bet.
Okay. So one of the things that's you know, really exciting about you know, the way in which this committee meeting has evolved over the last several months is the opportunity to bring before you some phenomenal work that our teams are doing to make things really great for our patients. One of the true crowns in JPS's, sort of jewels in JPS's crown is our comprehensive stroke program. They were once again evaluated by the just had their survey back in July, and as they do every single year, because with stroke they come every year, they got to be ready. It's amazing. They just once again blew it out of the water, showed that we're a true leader in stroke, and as you'll see, even where there are challenges, they immediately come up with plans for things they can do better. And the challenges with stroke are that intentionally the accrediting body moves the bar. They intentionally move the bar to get to try to improve stroke care in this country more and more and more and more every year. So they set the bar a little higher, a little higher, a little higher, and every year our teams figure out how to meet and exceed those new requirements. So I'll turn it over to our stroke team, our fantastic stroke team, Lori, and if Dr. Huggins is here, and Bernadette, to talk about where we are with the stroke program, talk about our survey, and where we're going for the next 12 months.
Okay.
Thank you so much. Thank you for letting us be here and presenting what's new with our program since a few years ago when we presented up to the board before. If we can go on to the next slide, we'll kind of get started in our numbers. So you can see this is through August of 2020, and our numbers, it shows 389 so far this year, and that's through the end of August. It is a little bit softer volume than what we had expected, and our numbers in the height of some of the COVID spikes actually dropped significantly. And that's a phenomenon that's been seen throughout the country and actually throughout the world. When countries or areas are peaked with COVID volumes, people don't come to the hospital, so they stay home, their stroke gets worse, we've had more cardiac arrests come in for our AMI program. So that is something that we are seeing. The good news is, though, the patients that do come in, we are really doing a phenomenal job of treating those patients. 86% of our patients get alteplase, or the clot-busting medication, within 60 minutes or less. So across the country, we are right there with all the leaders across the country, which are between 85 and 90%. So we are doing a phenomenal job. Even when our patients don't come in on time, we still take great care of them. One of the things that we're very proud with our program is we do have some very phenomenal outcomes. We can go to the next slide. So one of the ways we achieve these kind of results is with consistent education. So we keep saying the same message over and over again to nurses, physicians, and all of our ancillary staff. We provide feedback to and from the team. So we receive feedback, and just to give you an idea, is we had a delay in a registration that caused a delay in a CAT scan, and we couldn't get the images over. That happened yesterday, and we're already determined what the problem is, and we're moving forward to fix that. So we turn on a dime to make sure that we're taking care of things that our patients need. So we send information out to the team, you know, great job, you gave alteplase in 13 minutes, and right now that's our time to beat. So the ED has taken some of these things and now make it a great contest so that they can see who has the biggest or the smallest number, I guess I should say, who has the best time. And we look for some of those things to make sure that, you know, not only are we getting good numbers, but we also know those numbers relate to our patients. So the sooner we can treat a patient, the sooner we get that vessel opened, that blood flow restored to the area of the brain, the better off and the more likely that patient is to be independent again. And that's really what our goal is here for our stroke program. We give kudos to the team, and we'll go over a couple of those here in a minute. And we quality review, and Bernadette and I go through every single potential stroke patient on the front end. If anything untoward were to happen, yeah, Bernadette's kind of sitting behind my shoulder here. If anything untoward were to happen, then we actually go through that with a deep dive. We MIDAS what's needed. We take it up to our stroke committee. That gets put to peer review if necessary, MIDAS if necessary, whatever else we need to do for it. If we have any equipment failure, so one of the things we were tracking was our CT times and how often the CT scanners were down. So that's how we got the Philips machines removed, just by documenting that. And our stroke program was quite instrumental working with the radiology department and the ED trying to get those scanners documented and the amount of downtime we had on those. So we are on top of it. If you notice on that little graphic, the second red line, I don't know how well you can see that, but it says target stroke type 2 diabetes honor roll. That's brand new this year. So not only has our stroke program made strides with stroke patients, we've actually hit award level in the national benchmarks for diabetes for our stroke patients. So that is looking at do we treat diabetes? Do we recognize it? Did we do education for it? And did we provide medication for it? And an outpatient follow-up visit. So all of those, and we made honor roll, and I'm very proud of that one also. Okay, go on to the next one. So we are certified by DNVGL. That is Det Norske Veritas, and that is a Norwegian-based company. Their headquarters here in the U.S. is actually in Houston. We are a certified stroke center, and we recertified last year in July, and that was a very successful survey. They had a few findings, which they always will. It's very rare to go through any kind of survey anymore where you don't have any, because then they're not really helping you grow and helping you move your needles where they need to go. So our survey this year was in July. Usually they're in July every year. We had a virtual survey due to the COVID restrictions. We actually had the same surveyor we've had every year, so we usually have two. And the second surveyor was someone under orientation. And the reason they wanted her to come to JPS is because of the way we present our information and our data, the people that we are, because they're very excited because what they said is our pride, passion, and humility showed through even in a virtual realm. They said it was almost as good as being there. But when they interviewed staff and Bernadette, myself, Dr. Huggins, Dr. Gerstel, and some of the other physicians that are involved in our program. So all of our 2019 findings were cleared, and we had a very successful survey for 2020. We're going to go through some of our kudos on the next slide. So for DNV, we have 29 metrics. 8 of those are the primary metrics, which most people who've been around a stroke center for any length of time know as the core measures. And then we have 21 comprehensive stroke metrics. So with the comprehensive stroke metrics, we're looking at your more complex patients. So we're looking deeper into stroke treatment with alteplase, of the clot busting drug, into interventional radiology or thrombectomy. We look into things like the hemorrhagic stroke patients. So that's something that's not surveyed at all on the primary side. So our key metrics, we saw it in the first slide, our door to alteplase in less than 60 minutes. So there's 3 goal times with this now, 60, 45, and 30-minute goals. So within 60 minutes, we did 86% of patients received alteplase in less than 60 minutes. And less than 45 minutes, 71% of those patients received alteplase in less than 45 minutes. And of those that received it in 60 minutes, almost half of the patients that received it in 60 minutes had it in half of that time in less than 30 minutes. And like I said, our best time to beat right now is 13 minutes. They saw that patient come through the door. They knew exactly what was going on with him. They ran him to CAT scan, and he had been here with similar symptoms that resolved about a month prior. So they saw the CAT scan, they saw what was going on, and they had it mixed and ready before we even had the result. As soon as the result was back, they gave the medication. So kudos to the team, kudos to the ED for doing such a fantastic job. We started, and the 30 minutes is a new goal for October, from October, or from actually the start of our fiscal year this last year. And we were initially only doing 10% of our patients, so we thought 30% would be a high-reaching goal. And as if you know our ED physicians and our ED staff, put a goal in front of them, they tend to strive to meet it, like most of our JPS employees. So we have 40%, so we've blown that goal, and we're going to have to make it a much higher goal for next year. Next slide. So how do we make our program better? And what are our opportunities for improvement? Well, we got kudos on the times I just showed you, but some of our opportunities are a modified rank and score on all patients, and they wanted that on our data presentation. So what we normally had been tracking is, did we do one as a pre-hospital score and a discharge score? So the modified rank and score is actually a disability score. Most of us that are here on this call are going to be a 0 or 1, and that's considered normal or independent. Deficits of a 2 or a 3 can be semi-independent. You might need maybe some kind of a sock aid or something to put on your socks, but you can still dress yourself. You can still brush your own teeth, brush your hair. You can get up and do what you need to do. So you can function, and most people would be able to work or do other things that they would need to do. When you get into a 4 or 5, those are people who really need some strong care. So someone in a 4 might be wheelchair bound, where they can't do all of their activities of daily living, but they can maybe function somewhat independently. So maybe they can fix their own meals, but they can't necessarily put their pants on or something like that. Someone who's a 5 is bedbound, and someone who's a 6 is no longer with us. They passed away. So we scored the pre-hospital and a discharge, and then we score a 90-day modified rank-in by phone calls, which Bernadette and I do, on treated patients only. So anyone who received alteplase or thrombectomy, the IR care, those patients get a 90-day score. They challenged us to present that at the stroke committee meeting in a little more meaningful way. So beginning in August, we did present that data, and that is under construction. It went over fairly well, but we're going to tweak it a little bit, make it even more meaningful as we go. And we're including the 90-day follow-up scores. And what we've noticed is sometimes on our 90-day follow-up, stroke may be a second or third diagnosis, not the primary diagnosis at discharge, but we're going to be including those patients if it's a 90-day follow-up. So all of those patients will now be included. So that was something we discovered in August that we're going to continue on through September. So as we move, we'll have much more robust and meaningful data to keep presenting. And this is really showing us how well our patients recover once we've treated them, or once we've cared for them here. So that's really what the goal is for that. The other little piece that comes up is the Neuro Assessment. And that one keeps tickling us every now and again on survey. There's extremely intense vital sign and nursing assessments that have to go on with these patients. And if we miss one on one patient out of the 80 or 90 patients that we treat per year, that's a finding. So that's very intense information. And we just keep circling back and reminding staff and doing feedback to get them resolved. So thrombectomy, that's kind of the newest kid on the block, or our newest weapon in the battle against stroke. So what this is a mechanical removal of the clot. So we have alteplase, which is a chemical removal, and we have thrombectomy, which is a mechanical removal. So the whole goal of either of these therapies is to restore the blood flow in the brain to decrease the size of stroke. And in some of these patients, we've actually been able to see a clot, remove a clot, and the repeat MRI 24 hours later is negative for any stroke, and their symptoms have completely resolved. So if we can get to someone quick enough, time is brain, we can actually stop a stroke in its tracks. And we've done that with 2 patients since we became a comprehensive center. So I'd love to do it with a lot more, and we just got to get them coming back in on time again. So improved door-to-device times. This is one of our findings. So the device can be a stent retriever or suction device. So a stent retriever or stent retriever is like a cardiac stent. It's kind of like a little mesh, but instead of being a nice round stent, it actually will flow open, and it gets pushed up through the stent, and then it pops open, and it captures pushes up through the clot, pops open, and it captures that clot in the mesh itself, and then as it pulls in, it pulls the clot back down around. We've done it with just suction, so that's been fairly effective for some of our patients. And it's very similar to a heart cath, only we're doing it in the brain instead of in the heart. So again, sooner is always better. Slide. So just to give you an idea, I know not everyone here is in the medical team. So on the bottom left slide, that blue arrow is pointing to an abrupt stop in the blood flow or the contrast flow. So you can see, if you look on the slide above that one with the green arrow, at the very bottom of that green arrow, the very base of it, that's where that clot had occurred. So all of the blood vessels up above that arrow were all opened back up. And I know not everyone knows the anatomy, but this is a basilar occlusion. That is the widowmaker of the brain. Basilar occlusions are extremely high mortality and extremely high morbidity if they are allowed to complete. So being able to remove this is phenomenal for the patient, and this patient actually did extremely well. So if you look on the right side, very similar. If you look at the blue arrow, you see there's no blood flow beyond that arrow. And if you look at the circle in green, all of those vessels were opened back up by removing the clot. So again, we're restoring blood flow to tissue in the brain, restoring the function of that territory of the brain, and allowing patients to get back to independence. And that's our whole goal. Next slide. So how do we make their program better since we can do these things? Well, we found we're having some delays, and we actually found this just prior to COVID showing its ugly face in our area. So we had looked at it. This was a new metric. Instead of door to puncture site or door to sheath, it's now door to device. So that's taking an extra 10 to 15 minutes really off the time that we were striving for. And what we found was we were not making those times back in December, January, and we started an FMEA, and then we kind of had to shut everything down because we were more worried about patients surviving COVID than kind of our times, and we had to use PPE and all of those things. So we knew that was extending some of our times. So when we looked back after survey, we found some things that were a little bit concerning. So our longest time door to device was 276 minutes. So that's just over 4 hours, about 4.5 hours. And that's kind of a long time from the time they hit our door until we're actually there trying to remove the clot. And our best time was 165 minutes. And with a goal of 90, that's probably, or sorry, our average time was 160 minutes. And with a goal of 90, that's still almost twice as long as it should be. And they've added 3 additional metrics this year for 2020, for our fiscal year 2020, is door to revascularization, which is a TK2B. So the TK scores are 0 to 3, 3 being fully open, 0 being I couldn't do anything, it's still closed. So 2B is almost open, 3 is open. And fiscal year to date, if we can get there and get the clot out, we have 84% of our patients get a TK2B. So really, if we choose to intervene, we have really good success. Door to TK2B in 120 minutes, we have not been able to do. So we've not been able to get the patient in the door and get the clot removed in less than 120 minutes up through August. Brain to revascularization, so if we can get the sheath in and deploy the device, we can do it almost 54% of the time in 60 minutes or less. So once we get there, we do a good job. So we had to figure out why we weren't getting there. So we can go to the next slide. So what we did is we looked at this probably about 10 different ways, and we kind of settled on what were our best cases in 2019 versus our best cases in 2020, and where were areas that we could improve, because our door to sheath or groin or site access were much closer to 90 minutes than our door to device had been. So we looked at it, and kind of first things we noticed, oh great, our door to alteplase or the clot busting drug, those have gone down, and we knew those were going down because we had the data to show that. But then we noticed our door to notifying or calling the interventional radiologist, IR, and that went up almost 30 minutes. So that was kind of our first, aha, we need to fix this. And then if you notice the 3 other yellowed boxes, if we can remove that 30 minutes, most of those look pretty manageable, and we can probably get those times down with just a few tweaks. So that was the first thing that we thought we would tackle. We can move on. Next slide. So our action plan for thrombectomy, and this was started just prior to survey, and we really pushed hard and moved forward with this. We did some education with the ED physicians on when to notify interventional radiologist, and that was when the scanning starts. So when we're doing the imaging, that's a CT perfusion and a CT angiogram. Those are looking at a territory of the brain that's worth saving, and the roadmap, the CTA, to get there. And then we're going to monitor each and every case, which we were doing anyway, but we're going to do a much deeper dive on those, and then we're going to provide feedback back to the treatment team. And all of these cases will be reported to the stroke committee monthly. We don't have a lot of them, but we're going to report every single one of them. One other thing that we were able to do is it was added in the October budget, and it was approved to move forward, and the contract is already at legal, is to purchase rapid artificial intelligence software to add to the CT scanners. And what that will do is put the imaging quicker access, so they can actually see imaging from their phone and get the alert from their phone for the interventional radiologist, the doctors that are actually making the decision on whether or not to treat these patients. So they may be getting the alert right around the same time that they're getting notified by the ED that there's a patient that they need to consider. So they're getting kind of a double whammy, and we're gonna, hopefully once we get this in place, really start improving those times even more. But we do have some early data. We can move on to the next slide. So we actually had 2 cases in early September. Both cases, the decision was made prior to the results in EPIC for the CT angiogram or the CT perfusion. One case, when the patient came in, was not really protecting their airway, so that patient was intubated emergently in the emergency department. So that patient is excluded, because when we have to try to make sure that we're saving someone's life, that they're still going to be alive for us to be able to treat, then we can exclude them. So that's one of our absolute exclusions. So that patient was excluded. We had a little bit of a delay because we intubated her prior, then we had stabilizer to get her to CT, and then we got her up. And she actually had a great outcome. Her initial NIH was 22, or her, if you want to look at her modified Rankin that I talked about earlier, was probably a 5. So she was going to be bedbound, and she went home with a 0, an NIH of 0. So she did a phenomenal recovery, and I'm very proud of that one, and Dr. Huggins and his team for treating that patient. On our second case, door to first pass or device, so door to device, which was a stent retriever in this case, was 144 minutes. Much better than the 276 minutes or 165-minute average that we were having. So if we compare that, we've actually decreased the door to thrombectomy time by 21 minutes. And the notification to IR was done in 30 minutes from time the patient arrived. So we've actually decreased the door to notification down by 30 minutes also. So we did some phenomenal work, and it's paying off, and our patients are reaping the benefits. And then the last slide, just this is what we presented during our survey for our stroke committee members. Unfortunately, that very top one, the Vice President of Patient Care Services, has retired, and we will miss Trudy very, very, very much. If you have any questions about our stroke program?
An awful lot of data. Looks like you guys are doing a pretty good job.
We try.
Do you do any type of pre-hospital teaching, i.e. to MedStar folks?
Yes, we do. Yeah, we not only give feedback to MedStar, so on those 2 cases I mentioned, both of those patients were brought in by MedStar, and the day after those patients were treated, they had information back to them on how the patients were doing.
Great.
So we provide feedback directly. I am part of their outcomes, their quality committee. So I sit on their quality committee. And we also have kind of a joint member. So one of their medical directors is actually one of our ED physicians. So we do provide education through that also.
Great. Picture at the bottom looks sort of like a mob.
We have our masks on.
Thanks to Photoshop, we all have masks on. Very good.
That was taken before we had to wear masks.
Yeah, I know.
Presented after we had to wear masks.
Dr. Huggins, do you want to add anything to that fantastic presentation by Lori? Thank you so much, Lori, for presenting, for all the work you're doing. Great quality work. It's just really remarkable effort on the part of everybody in this stroke program. But as one of the medical directors, would you like to make any comments, Dr. Huggins?
Yeah, I'll try to keep it brief. I know everybody's got a lot of things to talk about today, but first of all, Lori does a great job. We couldn't do it without her, and now Bernadette's helping a lot. But these cases, when they come in, can be very challenging, and a lot of things have to happen synergistically in order for us to be able to treat them in these timely manners. And so we've done a very good job over the last several years of improving our medication times, and our next challenge of these thrombectomy times, it's going to take some work, but we'll get there. And so I just want to thank the rest of the hospital for supporting us, and it takes a lot of different departments to get this done. So thanks you to everybody.
I will also add, Dr. Weber, that when you talk about physicians and their commitment to patients, Dr. Huggins is definitely one of them. He has been stellar in the emergency department, and when we've seen changes in the ED, Dr. Huggins has played a key role in that, and I appreciate his physician leadership, but I also appreciate his friendship. He is he's good to this organization and very good to our patients.
Appreciate it. Thank you.
No, you folks have a lot to be proud of with this kind of data.
Well, we have to do it for the patients.
Absolutely.
It's
so
sad to see someone come in who was fully functioning an hour ago, and they come in and now they're completely bedbound. There's nothing we can do for them other than work them up as quickly as possible and hope that we can give them or offer them some type of treatment that can resolve that clot or restore their function as quickly as possible. It's nobody expected to wake up and have a stroke today, and we want to do the best we can to get them back home and back with their loved ones and functioning in their life again.
So my grandfather died years ago, not long after a major disabling stroke, and back then, and that was in 1990. Back then, if you had a stroke, you had a stroke. That's what happened. You might get an asprin, but you'd recover to whatever degree you could. Your brain could recover in terms of finding new connections and stuff, and it was all about rehab and that sort of thing. What our team is doing here is literally a game changer for patients. To come in with, as Lori was saying, somebody who's going to end up being totally bedbound, and they walk out of the hospital with a Rankin score of 0, totally capable of independent life, as if nothing happened. I mean, that is a game changer for our patients, and it is an absolute thrill to be able to provide, to be at a place like JPS, which can provide that kind of care for our patients. And that, the public health thing for those who are watching on YouTube is, stroke is an emergency. That's a 911. You got to come in right away, because if you come in right away, then you're eligible for these kinds of treatments that can absolutely, restore you to normal health in many, many cases. So thank you to the team, and just outstanding work. And thank you for putting this great presentation together for us today.
Thank you for having me.
Any other comments or questions for Lori, Dr. Huggins? Outstanding is what I would say.
Thank you.
Good gracious.
Thank you.
You'd have to have a real appreciation for what it's like to come through the door of our emergency room, to get everything done that needs to be done into the radiology suite, and have this done either by thrombectomy or drugs in less than 2 hours. I mean, 10 years ago, this wasn't even available. So Rob's given a pretty good summary of it.
Yep.
All righty. Well, put this date down on your calendar for next year.
You got it.
You're going to be back.
All right. We'll be here.
Thank you very much.
Thank y'all.
That's all I have for the open session. We had one item for closed session, if they can give us a couple minutes to clear the room, etc. We don't have any privileged stuff, do we, Cheryl?
All right.
No, sir, I don't believe so.
Okay.
Not the quality.
Jeffrey, just let us know when it's okay to go to closed session.
1.
This is to reconvene in open session for deliberation and/or actions deemed necessary regarding any matters on the closed session agenda. There weren't any, so I would entertain a motion that we adjourn at 2:49 or 14:49 hours.
Move to approve.